Come to the discussion on managing carcinoma of breast. Before I discuss few clinical cases as we usually do in these clinical case discussions, first I'll discuss few principles behind managing carcinoma of breast. Simply because the management of carcinoma of breast has been changing over the years for a better outcome of the patient and based on a lot of research, and also there is so much of available data on this. uh, Actually it's a sometimes it looks very complex, but there are so many variables to consider, but to make it to make it simple, I'll discuss in a simple manner the management of carcinoma of the breast, especially the principles involved. But of course per patient, you have to take decisions according to the patient. But anyway, uh, there are just three things that you have to remember in managing a carcinoma of the breast. Number one is that you have to make a diagnosis, and then look at the TNM stage. And according to TNM stage, you decide either it's an early breast cancer or whether it's an advanced breast cancer. And then the treatment, there are two forms: locoregional treatment and systemic treatment. And why we stage into two types, early and advanced, two broad categories? Because in the early breast cancer, your treatment schedule go uh, in this way. First, do the locoregional treatment and then uh, provide the systemic therapy. But in the advanced breast cancer, you reverse the order. First, you start systemic chemotherapy and downstage the disease, and then perform the locoregional treatment, and of course follow up with further systemic therapy. So these are the only three things to remember: diagnose, look at the TNM stage, and if it's early, do the locoregional treatment and systemic therapy. If it's advanced, chemotherapy first, downstage, then the locoregional treatment, and follow up with systemic therapy. So we'll just take one by one and look at uh, first the diagnosis. Now, diagnosis of carcinoma of the breast. Now, as in any disease, the diagnosis, it involves the history taking, examination, then investigations. So now this common term of triple assessment is there for carcinoma of breast, which actually in any disease it is there. But what is this triple assessment? The first one is the clinical assessment, that is your history taking and examination. And then you make a diagnosis, a working diagnosis, whether it's a CA breast or whether you think whether it's a benign breast pathology. And then the second step of triple assessment is the imaging, which is either ultrasound or mammogram. And for people below 35 years, the investigation of choice is ultrasound scan. But over 35, you can use both. And in special situations, you may use MRI scan, only in special situations. Then the third component of the triple assessment is making either a cytological or a histological diagnosis. Now in current practice, it is a histological diagnosis which is preferred, which is done by a core biopsy. And the core biopsy, even if the lesion is palpable, it is best done with image guidance. So this is your triple assessment. So this is the pathway of making a diagnosis. But there's another pathway to diagnose carcinoma of breast, that is screening. So in screening, there is no clinical evaluation, especially in the population screening. That is like in UK, they screen from 50 years to 70 years of age. And of course, they have plans to bring this to 40. But there, the population, the females in this age group, everybody undergoes a mammogram. Current practice there is to do once in 2 to 3 years, but there are countries which recommend once a year. But anyway, they do a screening mammogram. There is no history taking or examination. Do a screening mammogram, and if they find some suspicious lesions, they do further imaging with a guided biopsy. So your diagnosis of carcinoma breast you may come from these two arms, either triple assessment or screening. The aim of doing a screening program is to find the disease at an early stage. A few things about the normal patient who turns up to the clinic. The triple assessment. Now, your normal things about the lump, you ask the duration, whether it's getting bigger, is there any pain, things like that, and also like nipple discharge, and if you had fever because it may be inflammatory problem, and then you have to do some form of a systemic inquiry, especially if it's a you suspect it's a CA. It can be a systemic disease already by the time you diagnose. So like persistent headaches, or bone pains, respiratory symptoms, abdominal symptoms. They are important because the breast cancer can spread to any of these organs. And then, of course, your balance history is also important, like your past medical, surgical histories, and also the family history. There's a family history of carcinoma breast, and also the drugs they use, social habits like smoking, alcohol, and also in this history taking with a person with a breast lump and any disease, of course we do this, and you people look at what are called risk factors. Now, risk factors for breast carcinoma, there are many, but it is easy to remember majority if you think that the risk is increased by exposure to the female sex hormones. So obviously the risk is high for the female. Now we know that breast cancer can happen in males also, but obviously being a female, you carry a higher risk for breast cancer. Then age. So more time you are exposed to your female hormones, the risk is high. It's obvious, no? So with age, the risk goes up. And actually, the mean age in the European countries, it's said to be about 60 years. That's why these screening programs go from 50 to 70. But it doesn't say that a cancer cannot occur at a young age. Even cancers are reported in very young people in the 20s. But the risk is low. So we are looking at risk factors here. And also early menarche again, and late menopause. So that is you are exposed to your female hormones for a longer time. And what is this age early? What is this late? Now for menopause, probably looking at a lot of literature, it looks around 50. But if you give an example, if somebody attains menopause at 45 and there's another female 55, when you compare the risk, the normal risk, it is double for this lady. It doesn't mean that she has a very high risk, but the normal population risk is said to be double by this simply 10 years advancing menopause. And also all these are again increased hormone activity, and also increased mammographic density is also said to be a risk factor. Obviously the mammographic density is your breast tissue becomes more probably with the hormonal influence. And also family history is a risk factor, and these are risk factors, and you can look at this in a protective or high risk increase, whatever. So if you have a child at a young age, you are protected. So that means on the other hand, if you have a first child at a late age, you have high risk. So again, comparatively, a female who has the first baby before 20 and compared to one who has above 30, here again the risk population is doubled. And more children you have, more breastfeeding, it is protective. And also oophorectomy, it is definitely protective because you are taking off your female hormones. So here again you put in the other way, if you have only one child, the risk is high. You are not breastfed, the risk is high. Elderly primary risk is high. So you can put it in either way. But anyway, now what is the importance of looking at this risk factor? Now a person coming to your clinic, supposing all the risk factors are there, can you say it is CA breast? No, you can't. Of course, you have to make you have to examine mammography, your histology, everything has to be positive. On the other hand, there's a lady who doesn't have any risk factor except being a female. Can you say, no, you don't have a CA breast? No, you can't tell like that. So then what is the purpose? So this is not for the diagnosis of in a particular patient, But supposing somebody diagnosed to have CA breast, there are few things you may alter, like your taking hormones and your social habits, but all other things you can't change. But for a person, you at least few, there are few things if you identify you can change, because you can prevent the other breast getting a cancer. And also for population education, like to have children at a young age and to have more children. Of course, we have to balance with socioeconomic factors and to breastfeed the children. And then of course try and avoid HRT. But here also again, HRT if is used before 50 years, they say the risk is not very high, and some literature say it is there's no increase. But after 50, if you take HRT, the risk increases. But if you stop the HRT, the risk just dies off after about 4 to 5 years. So these are important points in preventive aspects actually. And also for to develop screening programs, all this is used. Say like to decide the skin probability 50 to 70, the age has been taken into consideration. But for a person, individual person, if there are a lot of risk factors, that type of people may be even sent for genetic studies. And people with very high risk, they may be subjected to screening at an early age, maybe even from 35 years you start screening. So these are the uses of looking at risk factors. They are mainly for preventive aspects, maybe of the population, maybe of the person for prevention, maybe of the person to decide when to start on screening programs. So that is the use. But anyway, going back now to what we were talking, that we have to make the diagnosis a triple assessment. So we have discussed the history into certain length, and then the next stage is of course to do your imaging, and that is your under 35 ultrasound. After that, mainly mammo, but of course you can supplement with ultrasound scan. And there is a lesion, you do a guided biopsy, and this is a either you can do a core biopsy, or some people they use a suction biopsy, and then you look at the histopathology. And also now in your in the diagnosis, another one thing that we said for the management is that we have to stage the disease, the TNM stage. So now we have made the diagnosis of CA breast by your triple assessment, the clinical evaluation, imaging, and then the true cut. And also another important thing is that we have to look at the TNM stage. And of course it may be too small here, but anyway, now anything up to T2 N1 M naught, it's easy to remember, but it is descending order 2 1 naught, T2 N1 M naught. So you can refer your textbook to various how you classify, but it is actually the T stage up to 2 centimeter, it is T1, and from 2 to 5 it becomes T2, and above 5 centimeter it becomes T3, and irrespective of the size, if there's either skin or muscle infiltration, it becomes T4. You can refer this in textbooks. And nodal status, if there are mobile nodes, it is N1, no nodes is N0, mobile nodes it is N1. If the nodes are fixed to each other or into the deep structures of skin, then it becomes N2. And also if there are ipsilateral internal mammary nodes, it becomes N3. And M is metastasis, and M naught is that's no mets, and if there is metastasis put as M1, but if you are not screened for metastasis, you put it as MX. So anything up to T2 N1 M naught is early breast cancer. Anything beyond this is advanced. That is, if this becomes T3, then it becomes advanced. But even if it's at N2 and this becomes N2, then it is advanced. So it's like that. So anything breaches above this any stage, it becomes straight away advanced. So you classify into early or advanced breast cancer. Now there's one important other point. Now when we diagnose a CA breast by a triple assessment and you look at the TNM stage, now metastasis. Now do we actively look for metastasis? There was a certain period where actually there was a metastatic screen, like you do few X-rays and then ultrasound scan, bone scan, like that. But now most of the centers, the current consensus is, if there are symptoms indicative of uh, meds, then you screen that particular. Say like people have bone pain, you may do a bone scan, or there are chest symptoms, do a chest X-ray. Abdominal symptoms, you do ultrasound scan. Generally, people don't now do a lot of screening investigations to look like metastasis, so you generally mark it as MX. But of course, if you're scan done investigations, you can put it as M0. But if you're not done and if positive, of course, it becomes M1. So anyway, so you have now made the diagnosis and you know whether it's an early breast cancer or advanced breast cancer. So this is what we were telling. So we have to remember only these. We said diagnosis, then TNM stage. So we have come up to that level and we know whether it's early breast cancer or advanced breast cancer. And we said if it's early breast cancer, we do the local regional treatment first, followed by systemic therapy. If it's advanced, you do chemotherapy first, downstage, then local regional treatment. But anyway, what are these local regional and the systemic therapy? We'll just have a look at them. So the local regional treatment is treating the breast and the axilla. The treating the breast and axilla obviously is a local regional treatment. Local regional treatment. Systemic therapy can be given in three forms. Hormonal therapy, because these are actually hormone dependent tumors, so hormonal manipulations can use for treatment, and also chemotherapy, which is generally a general thing in any malignancy. Then there are some forms of biological therapy. So we'll just evaluate one by one. Now the local regional treatment. So we said breast and the axilla. So treatment of the breast, it may be either a mastectomy, and now the term radical mastectomy is taken away. It's actually now called a total mastectomy. In the radical mastectomy, people used to remove the pectoralis muscles, but now the muscles are not removed unless there's some infiltration in that particular part. So it's a total mastectomy. So the local regional treatment, local treatment breast, it may be mastectomy or it may be a breast conserving surgery. So there are various forms of breast surgery. We'll just talk of one form, which is called a wide local excision. Wide local excision is that you remove the tumor with a margin of what you think is normal, and the margin macroscopically you mark. You mark the tumor, and around you mark the normal macroscopic the clearance, and you keep a 1 centimeter margin from the tumor that you feel. So this is a macroscopic margin. But later you have to look at the histopathology for the microscopic clearance, and the microscopic clearance has to be at least 1 millimeter. Some people say it's 2 millimeters, but it has to be at least 1 millimeter. If the margin has got positive, of course, that margin you have to do a re-excision. So anyway, coming back, your local regional treatment, it may be a mastectomy or a breast conserving surgery, which is a wide local excision, the most commonly used one. Then the regional treatment, treating the axilla, it may be axillary clearance or a sentinel lymph node biopsy. Why people move to the sentinel lymph node biopsy is that when you can't feel any lymph node in the axilla and your imaging doesn't show any enlarged nodes, those cases when you do axillary clearance, majority, all your nodes are negative for tumor. So there is actually no point doing all this clearance, because the axillary clearance itself causes a morbidity, early morbidity and also late morbidity by causing lymphedema. Sometimes they are very troublesome for the patient. So this concept of sentinel lymph node biopsy came. Actually, these are done where your axilla is clinically negative. If there are nodes, of course, then you proceed for axillary clearance. But if not, you do the sentinel lymph node biopsy, which is done by two methods, either radioisotopes, using radioisotopes, or using or using methylene blue, a dye. So you inject one of these two. Some people actually combine both. Around the tumor, inject around the tumor is one, or inject periareolar. And then you then dissect the axilla and see what is the first draining lymph node. So that lymph node you send for biopsy. So if you are using radioisotope, you take the node which has the highest intensity uptake of the radioisotope, which you believe that is the first draining node, and you send that for frozen section. And if it is negative, you don't proceed with your axillary clearance. So you stop with that node removal only. But if the frozen section come positive, then of course you have to proceed with your axillary clearance. So this is your loco-regional treatment. Treating the breast with mastectomy or a wide local excision, or and the axilla treatment, the axilla either by axillary clearance or sentinel node biopsy. And this you reserve for people whose axilla are negative clinically, but still you remove the first draining node, check the frozen section. If it is positive, of course you have to do the axillary clearance. And then another form of loco-regional, so this is surgical therapy, loco-regional treatment, surgical. And also for loco-regional treatment, you can use radiotherapy. Radiotherapy is also a form of local treatment. It's not a systemic therapy. You irradiate some target area. So radiotherapy is indicated for all the patients following breast conserving surgery, because you are removing the tumor and a margin, but you are leaving behind all your balanced breast. So your lump and 1 centimeter margin you are removing, and you should have a microscopic clearance also. So the balance of the breast has to be irradiated. So that's very important to remember. If you do your wide local excision, then you have to do this radiotherapy. People undergoing mastectomy, there are certain patients who needs irradiation. Now this, of course, there are various factors depending on the tumor size and the tumor stage of the tumor characteristics. So many things are there. So this, of course, you discuss with your oncologist, because they are the people who do this. And once you have completed your loco-regional treatment by mastectomy and your treatment of the axilla by one of these combinations, then of course you send for your oncologist. And for sure, people who have treated with wide local excision, they will give radiotherapy. But the people after mastectomy, looking at various factors, they will decide on this. So this is your loco-regional treatment, because we are just talking of these three things that we have to remember. Diagnosis we have done, TNM staging we have done, and loco-regional treatment. And then what is the systemic therapy? And we have said that the systemic therapy has 3 components: hormonal, chemotherapy, biological. So for your individual patient, you have to select using various forms of guidelines. So first we'll take the hormonal therapy. The hormonal therapy, it has to be given for a minimum of 5 years. So remember, it is minimum 5 years. And a lot of trials show now that you can go actually up to 10 years. So it's a minimum 5 years. So what are these hormonal treatment? The well known is the tamoxifen. So tamoxifen you give for the people who have estrogen, the hormonal receptor positive, estrogen or progesterone positive, or some people are positive for both. So for them you give tamoxifen. So this receptor status, the pathologist will tell you initially. If the biopsy is a true cut or a suction biopsy or a co-biopsy, in that itself they will get the receptor status. But if you have done a FNAC and operated, of course, on your the lump, they will give you the report. So that the pathologist will tell you. So if the hormone receptors are positive, you treat them with tamoxifen. And there is another receptor that we check, that is the HER receptor. And if HER is positive, tamoxifen is said to be less effective. But still you give, these are positive. So and one thing we have to remember is this also is a prognostic indicator. If HR is positive, the prognosis is poor. And then, so this is first form of hormone therapy. And for postmenopausal women, you also prescribe aromatase inhibitor. There is no point giving aromatase inhibitor for premenopausal women. So postmenopausal aromatase inhibitor. For premenopausal women, the oncologist will decide, they will consider about ovarian ablation. But more lot of people that we see in our clinical practice, of course, the majority are anyway premenopausal, postmenopausal. So this doesn't come, but of course, you mean young patients. So because if the ovarian ablation, they have better prognosis because you remove all your female hormones, and the CA breast is dependent on these female hormones. So premenopausal, if the diagnosis premenopausal, you have to consider ovarian ablation, either oophorectomy or by radiation. And then another thing I said was we have look at the HER receptor, and if it is positive, they are given Herceptin, and this is actually a monoclonal antibody. That's why I said there is something called biological treatment in breast cancer, the biological treatment. So if HR positive, you give Herceptin, and then whether chemotherapy is necessary. Actually, lot of people after treatment of carcinoma breast, after they finish their local regional treatment, there are lot of people receive chemotherapy. But of course, this decision the oncologist has to make using all these things, the tumor characteristic, whether hormone receptors are positive, because hormone receptor positive is a good prognostic indicator. HER positive is a negative indicator. Then whether lymph nodes are involved, how many nodes are involved, and the age of the patient, comorbidities, whether they will withstand chemotherapy, and is available genetic studies. So with this, the high risk people, they should be given chemotherapy. But of course, again, the oncologist will decide. But what you have to remember is that this has to be considered. So this part is easy. If hormone receptors are positive, give tamoxifen. Postmenopausal, aromatase inhibitor. HER positive, Herceptin. Chemotherapy, decide on patient characteristics. And for postmenopausal females, you also prescribe biphosphonates, because biphosphonates are shown to reduce the bone secondary related problems like fractures. And of course, some studies have even shown biphosphonates may even be protective against formation of bone secondaries. And also, when you start treating these people with these hormones, the hormone, this tamoxifen and aromatase inhibitors, of course, they have more chance of getting osteomalacia or rather osteoporosis. But of course, if you treat biphosphonates, this developing, the chance of developing a osteoporosis becomes minimal. So to reduce the bone effects, the bad side effects, you give biphosphonates to reduce the incidence of osteoporosis and also secondaries related problems. So again, so this is what we have now finished discussing: triple assessment or diagnosed by screening, look at the stage, and loco-regional treatment on breast and axilla, various methods available, and the systemic three forms of therapy. And if it's an advanced breast cancer, first start on systemic chemotherapy and then do the loco-regional and followed by systemic. And the systemic therapy we have discussed in length. So this is a very simple form of diagnosing and treating breast cancer. Now look at this clinical scenario. You can read for yourself, take a couple of minutes, read it carefully. So she's 60 years, a postmenopausal lady. She also has ischemic heart disease, and the breast lump, the size they are given, so that's a T2, and two mobile. So because they are mobile, they become N1. So it's T2 N1. Actually, this I made a mistake. This had to be ipsilateral breast, axilla. So it's the same breast. So sorry for that. And even the nodes, of course, if there are palpable nodes, that also you can subject to cytology. So the nodes have become positive. And this breast lump underwent a co-biopsy, and the co-biopsy has confirmed that it is a CA breast, and the hormone receptors they have given as negative, so it's a poor prognostic indicator, and also HER positive is a poor prognostic indicator. So using this and the things we discussed earlier, you can just plan what treatment you are going to give and just see how compatible it is with the way that we treated this patient. So CA breast T2 N1. Of course, we didn't assess metastasis here because she didn't have any symptoms suggest of metastasis. It goes as MX. So basically, you treat on N2 T2 N1 basis, and also hormones receptors negative and HER positive, and also yeah. So plans, you have some plan of the previous thing. You have planned for a local regional treatment and the systemic therapy. So anyway, now this is an early breast cancer. So we discussed the management options, and also, of course, with cardiac problems, elderly, of course, giving radiotherapy if you can avoid that is also good in a way, and patient also preferred the mastectomy. So the local regional treatment we did was a mastectomy, and because she had palpable, it was axilla was clinically positive, so then therefore you have to do axillary clearance. There's no point doing a central lymph node because when you send for PROSEM, very likely that will get a positive result. So she underwent a mastectomy and axillary clearance. And then the axillary clearance report, 15 lymph nodes had been removed. Generally, if axillary clearance is good, it has to be over 10 lymph nodes, and out of this 15, 4 were positive. 4 were positive. So now we have completed our local regional treatment. In our country, most of the hospitals, the standard operation, what happens most of the time, local regional treatment is mastectomy and axillary clearance. So in your exam, of course, you diagnose a CM breast and your treatment, you just suggest mastectomy axillary clearance. There won't be a problem. But of course, you can discuss further other options later on. So, but anyway, so now we have finished the local regional treatment. Now, radiotherapy is also a local regional treatment. So, will this patient need post-op radiotherapy? But one reason why we did mastectomy, we want to do our post-op radiotherapy. But of course, the oncologist will decide depending on the other unfavorable characteristics because she has lymph nodes positive, HER positive, hormone receptors negative. So, radiotherapy, the oncologist will decide, and very likely this patient undergo chemotherapy. So in your exam, of course, you can say at the end that I'll discuss with the radiologist, not the radiologist, the oncologist, whether post-op radiotherapy is necessary and whether chemotherapy is necessary. And this one, because it was hormone receptor negative, there's no point giving uh, tamoxifen. But of course, she is postmenopausal, so she was started on aromatase inhibitor and also biphosphonates. So it's a very simple thing. You made the diagnosis by triple assessment, and then it was early breast cancer. So you do the local regional treatment first, and we decided on mastectomy and axillary clearance. Why axillary clearance? Because it was clinically node positive, and discuss with the oncologist about post-op radiotherapy and chemotherapy, and the hormonal therapy. There's no point giving tamoxifen, but you postmenopausal you give aromatase inhibitor and also biphosphonates. Look at this. Read for a while and then plan your management. So a bit of a younger lady, and then this is again a T2. So there's no skin or muscle attachment. T2N naught, T2N naught, and then of course, so this is your clinical diagnosis, and then of course you have to do ultrasound and mammogram, and then do a biopsy. You do a true cut biopsy or a suction biopsy or a core biopsy, whatever you call, and then of course the report came as an invasive duct cancer, and and the hormone receptors both are positive, HER negatives. It's a good prognosis. Early breast cancer, a good prognosis. And then we discuss with the patient, and here again it's early breast cancer. So you do your local regional treatment first. And this patient was happy to undergo a breast conserving surgery, and we did a wide local excision with a 1 centimeter margin. Then you have to check your histopathology, and also because it's a clinically node negative, a sentinel lymph node biopsy was done, which was also negative, so we didn't proceed for a axillary clearance. And then the histopathology, the deep margin was 3 millimeter. Others were more than that. Deep margin, of course, there's a limit that you can achieve. So anyway, it's a successful removal, and here post-op radiotherapy is mandatory because it's a wide local excision. And then your hormones being positive, you start on tamoxifen, and there is no need to give Herceptin. And also premenopausal, there is no indication to give aromatase inhibitor. But of course, with your oncologist, you can discuss whether the person will need any form of ovarian ablation. The chemotherapy, the oncologist will decide. Of course, there's a lot of favorable factors, so it may be not greatly indicated, but of course, the oncologist will decide. Then look at this one. First read this part only. 50-year-old lady, and the by size it is coming to T3, but of course there's skin infiltration, so it's a T4 tumor. But anyway, with this T3, T4 both becomes advanced breast cancer. But of course, this is the main thing. It's a T4, and also clinically axilla is also positive. So now this is a T4 single lymph nodes, it's T4N1 and MX. We are not screened for METs, but advanced breast cancer. So the protocol, we do the systemic therapy first, neoadjuvant chemotherapy, which will downsize the tumor, which will downgrade the tumor. Actually, in some countries, after downstaging, you can discuss with the patient and do a wide local excision. So we raise staging, it come actually to nearly T1 level. But anyway, she's a elderly lady and advanced breast cancer. We did a mastectomy. So axilla, we were clinically positive, we have to do axillary clearance. This, of course, once you downstage, there are some countries, they think of course, you can do a wide local excision. But here, we did a mastectomy and axillary clearance, but of course, this option is there. But still, you have to do axillary clearance because it's a clinically positive. If you do a wide local excision, you have to give post-op radiotherapy. And then she had hormone receptors are positive, so she started on tamoxifen, and HER was negative, so there is no need of Herceptin. So, and then of course she very likely she will need chemotherapy because it's a advanced disease and lymph nodes positive, but that also the oncologist can decide. So you can go through this couple of times, and then you will understand what things that you have to do. Just only remember 3 things: diagnosis, stage, treatment with these 2, and in the advance you just reverse the order to start, and then local regional come back here, And the local regional treatment, treating the breast and axilla, you have many options of mastectomy, wide local excision for the axilla, axillary clearance or central node biopsy. And then you select according to. And systemic therapy, we have discussed extensively what are the parts of these various forms and what are the indications for each. So it's not difficult actually. And one point that I want to say is screening. Of course, you can read up about the screening programs, um, and then just practice. In our country, of course, there are no national screening programs, but on patients' interest and high risk people, it is possible to do screening programs. So you can go through these slides again, and then uh, just practice these clinical scenarios, and then of course when you see your patients, you can apply this again.